So thank you very much. Are you going to move for me, Cindy? I'll just tell you when. Oh, there is a clicker. Thank you, thank you, thank you. Yes, I'm Dana Siegal. I represent CRICO Strategies, a unique perspective here. We are a captive insurer of the Harvard Medical Institutes. Some of my peers are here today, and I'm delighted to be sharing the space with them. I am both humbled and heartened to hear so much expertise and dedication on this particular topic. As you can imagine, in a role like mine, where I spend 100% of my time studying the medical malpractice cases that come to us, and thus the voids and vulnerabilities and ultimate failures that impact our patients, it is really exciting to hear so much focus and energy on solving these problems. I'm going to spend the next few minutes trying to share with you some high-level data points. The purpose of this is actually to understand that our goal is really to use this knowledge not for finding out where the vulnerabilities and faults are in the humans, but where they are in our systems and how we can better learn where the patterns are that we can begin to approach as we want to focus our resources, human and financial energies, on solving problems. We use our data to drive those. So I want to share with you a few things we've learned. I have nothing to disclose. The most important thing for me to mention, however, though, while I represent CRICO, this is not CRICO-specific Boston-based data for the Harvard communities. We actually host a data sharing project with organizations across the entire country, which represents over 500 entities, 500,000 medical malpractice claims, now over 500 hospitals, 25 large captive and commercial insurers, representing about 30% of the database. So my peers at the Harvard community would be very distressed if I led you all to believe that these were our cases only. What do we know about diagnostic failures? We know that within our database, when we summarize them all together, this was a study of 25,000 claims where we analyzed the full claims records and the full medical record in each of these cases. And diagnostic failures appear third in volume and first in dollars in the loss associated with medical malpractice claims. Surgical treatment includes general surgery and all of the surgical specialties, and general medicine and all of the medical specialties. So technically, if you really think about diagnosis as a single entity, it really is our largest focus area for both volume and dollars. No surprise, a third of those diagnostic failure cases resolve around cancer-related issues. When we look at the specific cancers, none of this is really surprising to anybody in this room. This is really preaching to the choir. But it's really important for us to use this data to narrow down the opportunities that we can focus on for solutions. Lung, breast, colorectal, and skin. These can change on any given year when we look to order them. Ironically, this is a study that was completed in 2014. As we continue here in 2018 to add 2 more years, we actually learned that prostate has snuck its way ahead of skin cancer. So something to keep in mind as we look at those. The top primary responsible services, as you can see, radiology is 18% and pathology is 6%. Let's take a quick look at what they're contributing. Clearly, and we saw this morning in Hetty's slides, failure to order the diagnostic test, misinterpretation, consultation, and failure to reconcile abnormal findings. Radiology, breast, lung, GI, and urinary. Pathology, GYN, skin, breast, and head and neck. Again, probably no surprise here at all. The important things are elements to add to this data, and I know I'm going very fast. Happy to hang around afterwards and fill in any of the gaps. Misinterpretation of diagnostic study is one of the biggest vulnerabilities we're here to talk about. It's important to understand that we actually have multiple layers below that we can analyze. We're certainly looking at a number of perception areas, perception vulnerabilities. The area in concern is seen but not appreciated, or it's not seen at all. The vastness of the film or the pathology study does not include the area of concern. This is not only a perception area, but we recognize it as a communication and knowledge area as well. Did we, in fact, have enough information when we studied that film or pathology to know what it was, the clinical picture was that we were looking for? So while we talk about misinterpretation of diagnostic studies, we look at even the contributing factors underneath that misinterpretation and what information are we missing that contributes to that. In addition, communication to the provider, particularly for radiology, incidental findings, poor technique in pathology is consistently seen as well. When we look at Academic versus community. Mind you, again, this is a product of the denominators, the number of medical malpractice claims, already a biased set. But we see more radiology vulnerabilities in the community setting and a little bit more pathology vulnerability. And you can see here on the last slide the specific areas which again reinforce our need to collaborate and communicate and embrace our community peers, not because they're doing worse or better than us, but because they have a larger volume in which we need to help them support.
Terrific, thank you.